Good afternoon. On behalf of the Inter-American Development Bank, we welcome you to the event, An Investment Strategy for the COVID-19 Vaccine in Latin America and the Caribbean. A conversation between IDB President Luis Alberto Moreno and Michael Kremer, professor at Harvard University and the 2019 co-recipient of the Nobel Memorial Prize in Economics. The event will be in English with interpretation into Spanish. Para escuchar el evento en español, haga clic en el icono del mundo que encontrará en la parte baja de su pantalla y seleccione el idioma. Please send your questions to paulc@iadb.org. President Moreno, please go ahead.
Well, good afternoon, everybody, and it's a real pleasure to have with us today Professor Michael Kremer and his group, who I will introduce a bit later. But let me just at the outset begin by saying that there's nothing more important to deal with the pandemic of COVID-19 than the development of a safe and effective vaccine. The IMF, for instance, estimates that there's about a $375 billion monthly loss to the world economy because of this pandemic. And Latin America and the Caribbean, the economic output is projected to fall by $43 billion every month between 2020 and 2021. So we know that the world will need at least 7 billion doses of the vaccine. And this, of course, is of a scale never before seen. And countries do not have this kind of production capacity that currently in place. So the question is, how can we pre-purchase vaccines? And there's a lot of work that has been done around this by Gavi, by CEPI, by others. And certainly we at the Inter-American Development Bank are looking how we can help on a massive scale, help finance countries which are largely middle income, which most of the world is not looking at, to see how they can have access to the vaccine. Because the reality is that if you don't have some kind of pre-purchase agreement of the vaccines, you might have to wait for a year or more. We all remember the race for the ventilators. This would be nothing. It will tell in comparison what the race for the ventilators has been. So the question is how we can get around the questions of group purchasing. How can we lower the risk? How can we leverage buying power and obtain a greater production capacity? These are some of the challenges especially for middle income countries and for all countries as a whole. There's already a lot of work being done for the poorest countries. A lot of that work typically has been done, among others, by Gavi. Today, having the pleasure of having Professor Michael Kremer, which will present the Advanced Market Commitment Model, which basically is a way to successfully accelerate the development of the the vaccine. He will explain how the model can be adapted to, he did this for the pneumococcal vaccine, and how can this same model be adapted to COVID, to generate incentives for both manufacturers to start building large capacity needed to supply the vaccines to the world. Essentially, what is the push and pull factors that one has to develop? And of course, how can we do this better in Latin America? And so with that, knowing how time sensitive this is, we need to start to act now. We need a process of international cooperation which can help us ensure how to best get the vaccine. And we are, of course, at the IDB, this is basically part of our DNA. We want to help in this process, and we've already done a lot of work. And today, I'd just like to again welcome Professor Michael Kremer, who will be together with Juan Camilo Castillo and Susan Affey, who have been actually helping in the development of the model that he has for Latin America. So I know, Professor, you want to make a presentation, and then we'll start a conversation. Over to you, and thank you so much again for being with us.
Oh, thank you so much. It's a real pleasure to be here. Why don't I see if I can share my slides? Okay, so this is a joint work with a large group of people. Susan Athey's here. Juan Camilo Castillo is also joining us. Rachel Glenister at DFID, Jean Lee at the World Bank, Chris Snyder at Dartmouth, Alex DeBark at George Mason, Brandon Tan at Harvard, and I think I forgot Arthur Baker also. So many of us, as you just heard, many of us worked on a previous vaccine. We developed a concept for something called an advanced market commitment to encourage the development of a new type of vaccine for pneumococcus. So pneumococcus is a disease that is killing 1 million people a year. And there were vaccines already for the strains that were common in high-income countries, but not for the strains that were common in low-income countries. So the idea in that case was for a group of funders to promise in advance that if a vaccine were developed that was effective against those strains, there would be a market, and that would encourage the development of such a vaccine. So they would promise to help finance the purchase of the vaccines. We think that there are some similarities in this case, but there are also some differences. I guess I should have explained. That was adopted, a number of countries came together that made a $1.5 billion advanced market commitment, and now 3 vaccines have been developed against the strains of pneumococcus in developing countries, and those vaccines are reaching hundreds of millions of people. So we certainly hope that we get to the same point for COVID-19, and what this group formed, including people from who'd worked on that plus others, the idea is to think about the specific economics of the COVID-19 case, which we'll argue has some important differences. Okay. So as you heard, the economic losses are tremendous from COVID-19. The most recent estimates that we could find from an international institution were these World Bank estimates of 12 trillion in economic losses over this 2020-2021 period. And that works out to $500 billion. And at least as a crude approximation, you might think that every month that we accelerate vaccine development corresponds to 500 billion in economic gains, just taking that 12 trillion divided by 24 months. If you look at this for Latin America, you get 41 billion. Obviously, you could quibble with these numbers a little bit, but the point is these are enormous numbers. Now, if we think about the normal process for development of vaccines, it's a very slow and time-consuming process. And that's at least in part because the capacity installation for factories takes place. That's a very complicated process. Vaccine manufacturing is much more complicated than normal drug manufacturing. And that only takes place, the capacity is only installed after the trials are completed, because companies are typically not eager to incur that type of expenditure for large-scale capacity when they don't know whether their vaccine will succeed. And many vaccines do fail in trials. What's more, even after the capacities and even after testing is done and they're installing capacity, they typically build a fairly limited capacity, serving only the high-income countries initially. And there's typically pretty long delays, a decade or more, before all countries are served. So there's a number of reasons in terms of economic theory why that, even though that's what firms will privately do on their own, that might not be socially efficient. The private and social incentives may differ. And just to discuss some of some of the market failures involved, there's that may mean that private incentives, both for accelerating capacity construction, doing it simultaneously with testing, and expanding capacity, putting in a large capacity which allows a large flow of the vaccine to be produced to treat people much more quickly and avoid or minimize shortages. The private incentives to do that will likely be less than the social value. And there are a number of reasons for that. In classic economic theory, disease externalities. If I take the vaccine, that doesn't just benefit me, but it benefits others. In the case of COVID-19, there are also spillover economic benefits. If I can go out and interact with others, that may benefit others economically as well as me. Now, because of that, because of the individual incentives are not aligned with national incentives or global incentives, typically vaccines are purchased by governments. But that creates its own set of issues. One is that I think from a purely financial point of view, if a firm installs enough capacity just to serve the high-income countries, it can sell at a pretty high price. If there's enough capacity in the world to serve middle and low-income countries, that could put pressure on prices. So that's one issue that may create a further distortion. But there's also the issue that there can be political limitations on prices. And I think that particularly may be relevant for COVID-19, and maybe we can come back to that later. Now, there are some potential effects that could go in the opposite direction, business stealing effects that might mean, but I think those are likely much smaller. If you look at one sort of prima facie piece of evidence that firms don't capture all of the value from vaccines, is if you look at the reaction of the stock market to vaccine news. You know, when the first positive news started coming out on vaccines, you saw a jump in the price of the stock of the companies that were making the vaccines. But that gain in value was tiny relative to the overall gain in the stock market value. And of course, the gain to the total economy is presumably much larger still. So from the standpoint, I'm going to move away from theory to some calculations, but from the point of view of the economic theory, there's lots of reasons to think that firms might not move as quickly as would be socially valuable, and they might not move at the capacity levels that are socially valuable. So to switch from from economic theory to actual policy, what's happening in the world right now? Well, the U.S. through Operation Warp Speed and Europe through various initiatives are purchasing vaccines in advance of approval. So whereas the normal process is firms wait till install capacity until the testing is complete, what the US have done and what a number of European countries have done is they've contracted with the firms and say, we're going to pay you up front. This is a little bit different than the pneumococcal advanced market case. But what they've done is they say, we'll pay you up front and we want you to install the capacity now, and we're pre-purchasing the doses and we're taking on that risk. So the buyers are saying, yes, we know the vaccine may fail. If it fails, we're still paying you. But if it succeeds, we want the vaccine. So, I argued on theoretical grounds that private and social incentives might not correspond. But if we look at these actual programs, are they a good deal? Well, I don't have access to the full contracts, but reading the newspapers, you can get the basic terms. So the US paid AstraZeneca, that's a firm that's producing probably what's perhaps the leading vaccine right now, which is the vaccine developed by Oxford University. They contracted for $1.2 billion for 300 million doses, basically purchasing for everybody in the US who might want a vaccine. So was that a good deal? Well, if you can build the capacity, during the trials rather than waiting till afterwards, let's say that accelerates vaccination of the population by 6 months. Let's say that the success probability were only 10%. I hope it's more, but let's be conservative. Let's say it's only 10%. What would be the benefit cost ratio? Well, we estimate that would be 45. That's just because the gain from accelerating the available, as I said in the first slide, the gain from accelerating availability of the vaccine is so large. Now, you could do another calculation. That's just one shot on goal. Imagine you had, think, just do the, this is very crude, what we do in the papers, I hope more sophisticated, certainly more complicated, but take the case that these were all independent draws and that there were a bunch of candidates. There's more than 100 candidates out there. If all vaccines had a 10% chance of success and they were independent draws, it'd be worth taking 37 shots on goal. That would, before, that's the level of investment that would be worthwhile, even though that 37th vaccine obviously only increases the odds of a successful vaccine by a small amount. Just given the tremendous value of a vaccine, of a successful vaccine, it turns out that quick back of the envelope calculation would suggest that. Let's think of that as just giving you a sort of order of magnitude sense of this. So that was a calculation for the US. What about LAC countries? Well, we've done a similar, again, very crude calculation for Peru. For Peru, accelerating a vaccine by 6 months would be worth 5.6 billion. So that would be worth it. Peru buying this vaccine for all citizens would be worth it as long as the chance were at least 2.1%. But obviously, and as you'll hear later, we estimate based on the historical record that the chance is much greater than that. So these are very, in some ways these are these very simple calculations, I think, tell you a lot. I should emphasize that it's, another option. Let's say that for some reason it was difficult to buy for the whole population. Or suppose we're thinking about a very low income country, lower income than Peru, a Haiti, for example. Well, a lot of the benefit, a lot of the health benefit of vaccines comes from vaccinating health workers and the elderly and other vulnerable groups or key workers. So another option for low-income countries might be to not buy doses for their whole population, but only for the key groups, and maybe for 20% of the population or possibly even less. So, and of course, another option for a middle-income country would be to say, well, we'll buy some candidates that we think are very likely to succeed, we will, or most likely to succeed, we'll buy for the whole population. Others will make a smaller order so we can at least get coverage for the, if it turns out that one's successful, we'll at least get coverage for the most vulnerable members of our population. So let me give you a sense of what I'd like to talk about. By the way, Susan, Camilla, feel free to come in as seems fit. Let me give a little bit more background on the vaccines, talk about what might happen in a decentralized market for early access to vaccines, describe the equilibrium, briefly say a bit about a few other issues as well. I probably won't cover all of this, but we can come back in Q&A. Okay. So the model that we do, in some ways, is a more sophisticated calculation, version of the calculation that I described earlier. We use data from World Health Organization on around 100 vaccine candidates. WHO has data on the stage of development. What level of testing has each vaccine gone through? Also on the platform, there are many different platforms. There's protein subunit ones, there's viral vectors, there's mRNA, DNA, and some of these there's a lot of more experience for. Some are brand new. Based on the historical record of candidates at similar stages, based on the platforms, based on some expert opinion, although that differs, and with some downward adjustments, because we're wondering, could a candidate be ready in 18 months? We assign some probabilities of success. And I should say, that's a somewhat subjective exercise, but we try to do the best job we can, but we're also working on developing a version of this so that users could put their own assumptions in and see how the results change. We also allow for correlation of risks. That simple exercise I did before was assuming that all the candidates were independent, but of course they're not. Candidates, you might get a whole platform that turns out to be not workable for some reason. Then we also use some cost estimates, and these are based on discussions with various sources in industry as well as in bodies like CEPI, which is a I'll explain more about them, but they're on the buyer side at some level, on the public side. What are some of the institutions that are involved? I think that's useful background. Obviously, for the Americas, the Caribbean, PAHO plays a key role in buying vaccines on behalf, collectively, on behalf of the region. Gavi buys vaccines on behalf of low and lower middle income countries, but mostly, historically, mostly the very poorest countries, so not most of the countries in the region. Gavi is setting up something called the COVAX facility, and that has two components, or the plan is it will have two components. One, which is a funded component, which would be financed from donations from the higher income countries, and that would cover some countries in the region, Haiti, Bolivia, El Salvador, and so on. But most of the countries in the region wouldn't be included because their income levels are too high to qualify for that. And therefore, they would fall into what's called the self-pay component. So Gavi's plan is, for the COVAX facility, is that countries in this, that are not the poorest countries are going to have to pay themselves. Now, that leaves, I think, most of the region in this very awkward situation. Some high-income countries, the US, UK, a number of European countries working together, have gone out and they're signing these contracts they've described. They've already signed them, and they're signing more. The very lowest income countries, there are already some pledges, not enough, and I hope there will be more, but there are already some pledges from international donors to the funded part of the COVAX facility. But ironically, the place where the epidemic is most severe at the moment, the Latin American Caribbean region, that primarily is not covered by either of these, which means that there's a real danger of being left out. And that's why I feel I'm so excited to be talking here, because I think this is really this is both where the problem is most intense and where the institutional solutions are most lagging. Let me mention CEPI a little bit, since I referred to it before. CEPI makes some investments in the research and in manufacturing of vaccines as well. Let me actually explain one more thing about the vaccine manufacturing process. So the vaccine manufacturing process includes many different components, but some of these components are in fairly short supply. So, and particularly, they may be very difficult to expand the supply in the very short run. Long run, you could set up more manufacturing facilities for components like bioreactors, et cetera, but that might be difficult in the short run. So that takes us into the next section of the talk. We tried to think about what would happen with a decentralized market for early access to vaccines, because that's a large part of what we see now with countries like the US or UK going out and signing deals on behalf of their countries. And so the issue is, I just argued before that it's clearly worth it, not just for the US, but also for middle income countries to go out and sign deals like the AstraZeneca deal that the US signed. But there may be, that's true in a partial equilibrium if we take the prices as fixed, but there's a question, is there enough vaccine for all countries to buy? And when we talk to experts, they're very concerned about if you talk to the experts in the industry, they actually believe that there are capacity constraints on many of these inputs, and that it's going to be very difficult to supply the whole world. Now, I think economists normally think that there may be more elasticity out there than sort of engineers do. But I think we should recognize that it is just very hard to rapidly expand capacity. And so in the short run, supply may well be pretty inelastic. What happens when you have very high demand and inelastic supply? Well, you get very high prices. Now, what I think we don't know is how the politics of this is going to work out. There may be pretty strong political pressure to keep prices low. And that might mean that the price might be below the marginal social value of the vaccine. So standard economic analysis would say the price would go very high, and you'd get a bidding war for this. And you may also get, certainly AstraZeneca, they're charging $4 a dose. That's not a super high price right now. Maybe that's just a short run phenomena because we haven't had the capacity constraints, but maybe there's also some either desire by companies to not be seen to be profiteering, or some implicit threat of price regulation. I'll come back to this later, but we've done analyses both ways. I'm going to show you a case today where we assume average cost pricing, that there's some political pressure that keeps prices at the average cost rather than the marginal cost as we would normally assume. But prices could be much higher than this. Okay. As I said in the introduction, those were actual deals that were done today. If it's possible to buy at those prices, that's clearly a good deal. We can, happy to talk later about what happens if prices were higher, or to share the model. Okay, so what do we do to look at the decentralized model? We assume that every country can contract to purchase capacity from each of several different vaccine candidates. They have to pay a certain price to do that. We'll assume that the manufacturer for a particular candidate, what's being purchased is capacity. So it's a little bit different in our model than in the example I gave. It's not purchasing a certain number of doses. It's saying we're going to buy the capacity of this bioreactor. We're going to fund to put the bioreactor in, and then we can get the output from that if it turns out the vaccine's successful in trials. And we then solve for the optimal investment for each country, and there's two parts to that: how many candidates to invest in, and how much capacity to order for each candidate. We've made some, I would say, relatively optimistic assumptions compared to what we've heard from some of the people in industry about the place at which the extent to which you can expand capacity before costs really start to go up, because, for example, you need to start repurposing capacity that's been used for other things that have a high marginal cost of repurposing. So, and as I said, I'm going to show the case where we assume the price is the average cost plus a 20% markup, but we've also worked out the case with standard marginal cost pricing, or marginal cost plus some markup. We can do as well. Okay. What are countries buying when they're buying early capacity? Well, they're buying earlier access to the vaccine. So if you think about the case without early purchase, there'd be the medical trials. Then once those are finished, the capacity is installed, and then there's production. And what the early purchase enables is the capacity to be installed, if you see that red line, at the same time as the medical trials are being conducted, which means the production starts earlier. So we're looking at the incremental value of getting the production earlier, right? Or getting the output, getting the vaccines earlier. See if I can advance the next slide. Okay. What's the benefit of it? So look, when we solve the problem, how much capacity should countries invest in? The benefit is the more candidates they invest in, the greater the chance of success. So if you just invest in a few candidates, you choose the ones with the highest probability of success, and then as you increase the number of candidates, you're going to more and more marginal candidates, and obviously there's always the chance that one of the early candidates succeeded already. So you're getting, this tends to be a fairly concave function of the probability of success is a function of the number of candidates. So it's it's a very easy decision, as I argued earlier, to take at least one shot or 2 or 3 shots on goal or 5 shots on goal. But the richest countries wind up, to anticipate the results of it, they wind up saying we're going to take a lot of shots on goal. The other choice is how many doses, how much capacity. And there, the benefit of more capacity is you get, investing in more capacities, you get, if you get your population vaccinated more quickly. What do we assume for the benefits? Well, we take the World Bank estimates of the economic harm. We do the health benefits. We actually, we're probably underestimating the health benefits for the region, because we just assume 150K deaths per month. Obviously, there are better, more favorable scenarios, more pessimistic scenarios, but we think there's a right tail there, so we use that. But I said this is probably an underestimate for the region, because we're not assuming that those we have a single common worldwide death rate, and obviously the region is, at least right now, is suffering terribly badly. We don't know what will happen, what that will be when the vaccine, when or if a vaccine becomes available. And then we also allow for the fraction of the population of particularly high risk. One thing I should note is we allow for a 50% probability that either treatment or some other mitigation strategy, maybe we find very good testing and test and trace strategies. We allow for a 50% probability that that problem is entirely solved of COVID-19 before a vaccine is developed. And as you'll see, we still calculate it makes sense to make very large investments. I think that's the logic for that should be clear from the initial examples. The benefits are so overwhelming with the sort of 45-to-1 benefit cost ratio that even if there's some chance that vaccine, that by the time we have a vaccine, it'll be unnecessary. It's still worth, when you buy insurance, it's worth it, even though there's only a certain chance that you'll need to use it. This slide just shows the assumptions we make about the benefits to the priority workers and to the elderly. Based on some our understanding of the epidemiology, we assume that you get 75% of the benefits from the priority populations. Let me just mention some implication of this, which I alluded to a bit earlier, which is what we even if you can't buy for the whole population, in some cases our model would suggest buy for the whole population. If countries can't get the budget together to do that, if they can't go to the level that our analysis suggests is optimal, you get a lot of the benefit from even from a much smaller program, because a lot of the benefit comes from reaching these the health workers, the elderly, maybe a few other groups like other key workers. Okay, what are our findings? Well, this more sophisticated model gives the same intuition on the first bullet point as the back of the envelope calculation. It's in the interest of high-income countries, middle-income countries, even low-income countries to invest, although the low-income countries would come in with fewer candidates and to some extent smaller quantities. So the high-income countries, they would order a very large quantity, 12% of their population, enough to vaccinate 12% of their population per month, so that they could rapidly vaccinate the population. For IADP, it's a bit lower, but it's still substantial. Most of the investment goes to the most advanced candidates, but because you want multiple shots on goal, it turns out to also be worth investing in some of the risky candidates. We estimate the total benefits of this to be almost $1,200 billion, the total cost $322 billion. So it's a very cost-effective investment. Now, obviously, there are a lot of assumptions that go into this model. We're still working on it. We're constantly iterating on it. We have a list of things that we'd like to improve. But I think we're now at the point where we've got some sense that things are fairly robust. I don't want to say they're going to be robust to all the parameters, but they're robust to things that affect the benefits. So, I mentioned before the chance that another technology is developed. There are other things that would be isomorphic to affecting the benefits. And I think the qualitative results are quite robust to that. Some of the results on the amount you order and so on would be sensitive to where these, where you start running into scarcity of the supply chain components and prices start going up. But at some level, that's not the decision facing countries right now, because at least right now it's possible to buy at a quite reasonable prices. It could be that the prices are going to go way up once we run out of capacity, but we're not there yet. Okay. Here's something, I'm not going to go through this, but this shows some illustrative calculations from our preliminary version of our model we have now, and you can see the number of candidates that our model suggests is optimal to invest in, the amount, and you'll see, if you looked at this more, you'd see there's actually a fair amount of heterogeneity. You can see, if you look down at Bolivia and Argentina, you can see Bolivia is going to invest in more candidates than, Argentina is going to invest in more candidates than Bolivia would, just as an example of heterogeneity with income. Okay. You can also calculate what would happen if all countries cooperated in a centralized program. Now, some of the discussions of centralized programs, typically, I'd go further than some of the discussions. Many of the discussions at, say, the World Health Organization or within Gavi, people take the view, which is completely understandable, and which is that vaccines should be allocated based on health needs, not based on national income. So the first people to get the vaccine should be the health workers, the elderly, and then only after those people have been served in all countries, then you can go on to lower risk groups. So that's clearly what would maximize the health benefit of the program. But one thing to note is if you think about a world social planner and you think about the plans for individual countries, those two things aren't going to correspond. And the reason is that the optimal plan for countries depends on the national income. Countries are trading off, they have many, many needs, particularly at this time of COVID, and they're trading that off. And higher income countries would, if they're just thinking about what's in the narrow interest of their country, they would invest in more candidates, and they would invest in greater capacity for each of those candidates. Now, if you're adding up these individual programs for individual countries, and you compare that to the policy that would be chosen by a global social planner who's constrained to allocate the vaccines based solely on health, we'll see that the centralized program is actually smaller. There are larger health benefits because the vaccine is distributed by health need, but there's smaller economic benefits because the rich countries don't get as much access or as much early access. And I think that raises a question. I mean, there are obviously very important philosophical questions here and ethical questions, but this also raises questions of incentive compatibility, which is, would high-income countries join a world program that's going to allocate purely based on health need? Because what that would mean is that people in, let's take the US, for example. The US has launched Operation Warp Speed, and it wants to buy all these doses for the US, and it wants to be, to get those vaccine doses early. And it's not clear that the US would join a global program if that meant that prime-age adults in the US were going to have to wait longer to get a vaccine. So there's, as I say, there's important ethical and philosophical issues, but just as there's also just a question of would the US join that, and that may be an important issue for program design. Now, I think we haven't yet done the analysis for incentive compatibility within regions. So, Europe is talking about launching a program. It may be that the incentive compatibility, my guess will be the incentive compatibility issues within Europe are going to be much smaller. If there's a unified program for the region, for Latin America and the Caribbean, we haven't done that analysis, but I think it'd be interesting to see, is this incentive compatible? It may well turn out that it's not that difficult because some of the poorer countries are also smaller. Maybe something could be done, or maybe that wouldn't be incentive compatible. Happy to look at it. Here's another issue to think about, and I would say this is the area where we found maybe the biggest difference from the pneumococcus case, which is looking at the optimal combination of what we might call push and pull funding. So pull funding pays for outcomes. So in the case of the pneumococcus vaccine, the funders only offered to pay for a successful vaccine. They didn't, the risk had to be taken by the companies. And there's some advantages of that. It means the companies have an incentive to produce quickly, to produce something that's actually practically useful. The disadvantage, which turns out to be particularly big in this case, is that it tends to be expensive. And when I say expensive, that's in terms of the expected price. Obviously, you're paying more if you're only paying for success, but you might think that would all just cancel out an expectation. But it turns out not to. And the reason is that vaccine candidates differ in the probability of success. Some are more advanced, like the Oxford vaccine. Others are not so advanced. But our analysis suggests that in the case of COVID, because of the enormous economic and health costs, it's worth investing, it's worth investing in many different candidates. And that means that if you're relying entirely on pull, and you're just paying for you have to try to pull in the marginal candidate. And the marginal candidate might have a much lower probability of success than the more advanced candidates. So if you set the price to pull in the candidate that doesn't have such a high probability of success, you're providing rents to the more advanced candidate. And it turns out those are pretty large in this case. So it turns out that funding something entirely through pull would be considerably more expensive than relying on, than having a mixture of push and pull with a fairly large push component. So we would suggest that this push funding that has cost plus reimbursement for the capacity installation should have a pretty high component. And we've done our calculations assuming push funding covers 85% of the costs. And arguably, the US, and we don't know the details of those contracts, but it sounds like it might be going even further to 100% of the costs upfront. This is a judgment call, but I think we make some assumptions and so on. It's a somewhat heuristic approach, but we think it's probably good to have some skin in the game for the companies themselves. So that's why we're not suggesting going to 100%, but reasonable people could differ on this, and we can use the model to analyze multiple cases. Okay. Our model suggests that it's optimal to make quite large investments. I went over the slide with the table quickly. One thing I should emphasize, I noted before that those results are fairly robust to things that would affect the scale of the benefits. But I also wanted to note that one reaction would be, oh, we just can't come up with that amount of money, and therefore we shouldn't do anything. So I want to emphasize that our analysis suggests that there's still very large benefits from smaller programs. For example, if we look at this at the level of the globe, we estimate that it might make sense to spend, this was a slightly earlier version of our analysis, $150 billion overall. But you could still get 90% of the benefits at half the cost. So even if a country, for whatever reason, doesn't go for a full program, it's still worth making some investments in the highest probability of success vaccines and at least enough capacity that the key populations can be treated quickly. I think say a few more words on international coordination and cooperation. I touched on that before. I argued before that there are pretty big differences between what's optimal for different countries, and therefore between the global social planner and what's optimal for individual countries. And so that might make it difficult to agree on central global coordination. You know, there are additional issues if a program seeks to redistribute. So one could imagine so some of the proposals out there, in fact, I think, you know, where we first started, we thought, well, countries can pay in a certain percentage of GDP, and then they would get things allocated based on health needs. That obviously involves a fair amount of redistribution. And look, I would love to see that, I think, but it doesn't look like that's incentive compatible for the globe. At least we haven't. I think there's some willingness to pay for the poorest countries, but not to do the full scale redistribution. So I think if the region was thinking about something, you could design something that would implicitly redistribute within the region by having countries pay in percent of GDP. But you could also design things where, you know, each country would be purchasing on its own behalf. You know, Colombia would decide how many different candidates to pre-order vaccine for, what quantities, and they would pay for those doses. You know, one possibility is that another possible advantage of a global social planner is that they might be able to hold down the prices. You could, by just ordering, maybe reducing the total order of vaccines, so you don't go to the most inelastic part of the supply schedule. And so that would be another possible approach. In the analysis we just gave with average cost pricing, there'd be no reason to do that. But if you had marginal cost pricing, it might be the global social planner might try to hold down the price a bit. What measures for international cooperation might be feasible? Well, one thing I'd like to emphasize, some of these discussions are implicitly comparing what happens if each country is on its own to what happens if all countries are in a centralized plan. Well, each country on its own relying entirely on domestic production, that is actually terrible. That's terrible not just for, wouldn't only be terrible for, I mean, obviously it'd be terrible for Honduras, it'd also be terrible for Brazil, but it'd also be terrible for the US. You know, you really want multiple shots on goal here. And the US, you know, even a country with as big a vaccine industry as the US, they're going to want access to vaccines developed elsewhere. There are international supply chains for these. So export bans and autarky, even just a minimal, getting away from that is really, I think, a very minimal object for international cooperation. But I think there are other areas where international cooperation might be feasible. One is in R&D. Getting funding the basic R&D and the trials is in some sense a global public good. CEPI is doing some of that, and I think there's plenty of room to do more. Probably don't have time to get into this now, but the supply chain capacity is, you know, trying to improve the say, create more capacity to produce bioreactors. That probably won't help in the short run, but we could be facing a situation in which you know, the short run candidates don't succeed, or they do succeed, but then we need to keep up, we need to further expand capacity because, and expanding capacity now in the supply chain and say firms that produce bioreactors, I think would be valuable and would be, and I think there are reasons why that should perhaps be done at either at a global level or possibly at a regional level. There's also possible insurance benefits. We don't know, right now we don't know which countries will be most affected when the vaccine becomes available. Maybe by working together, we can agree that we'll, you know, say the countries in the region might say, well, we'll purchase through PAHO and we'll allow PAHO some flexibility in prioritizing who gets vaccine first, so that so that whichever countries in the midst of a severe epidemic then can, is a hotspot then, can get the vaccine first. Or obviously this could be done at the global level through the COVAX facility, or Gavi. Okay, lots of open questions. Let me just summarize some of our results and turn to one, I think, open question. What's clear is the huge benefits of accelerating a vaccine mean that even if the chance of vaccine success were much less than I think most people estimate, it's still worthwhile taking these bets. So yes, these are risky bets, but they're clearly, it's like insurance. It's a bet you want to take. And probably want to order fairly large capacity and diversify across multiple candidates. That's not only true for rich countries, but certainly for middle-income countries and even for low-income countries. I think, we think that there's some important differences with the pneumococcus case, and that the optimal contract in this case will largely take the form of an upfront payment to the firms to install capacity in exchange for an option to purchase at a price that provides some pull incentives. Now that does require an upfront commitment at a time when countries are facing huge financial pressures, and that's easy for an economist to say, but it's tough that this is worthwhile based on economic analysis. But actually coming up with the money is harder. And I think there's potentially, obviously we've got the experts here, but I think our analysis would suggest there might well be a role for multilateral development banks in helping provide the financing for middle-income countries, which are currently that don't already have the purchases lined up that some of the high-income countries do, and that can't count on the funded portion of the COVAX vaccine to address their needs. So would love to discuss that and other issues in the rest of the talk.
Well, thank you very much, Professor, and this has been a fascinating presentation. I know that we're short on time, and I don't know if either Juan Camilo or Susan want to add anything. I would perhaps ask them, and then I would just quickly have perhaps time for just two questions. Susan or Juan Camilo?
I think we can go ahead with questions.
Okay. No, so one of the questions is, if anything, what COVID has taught us is that international cooperation really hasn't worked. I mean, every country has looked after itself. And, there is all these variables out there. If you had the magic wand, now that we're, the reality is that in most of Latin America, with the exception of Brazil, I haven't seen any decision by any one country. In the case of Brazil, they made the deal with AstraZeneca and Oxford, and they already set up kind of a tiered approach of the numbers of vaccines they would do. What would you say if you had the magic wand? You talked about the centralized approach, you talked about the push and pull. Where would you say is the best way to put this together? Putting aside, of course, the low-income countries, which you outlined them there, which basically Gavi is going to try to work through them, but the bulk of the world today is middle-income and upper middle-income countries, in terms of population at least.
Right. So look, if I were a policymaker in the region, I would be trying to go out and do the same deals that the rich countries have done. And which way that's done, I think is, look, my personal preference would be to do that through some sort of international cooperation. I think that offers some advantages. So they could go to the COVAX facility, which has the self-pay component. It's not fully clear what all the design features of that would be. PAHO obviously has a lot of experience in purchasing vaccines, so that could be done through PAHO. They could do it on their own. I think that's I'm not an expert in the legal aspects or on I don't have a stake among the different institutional players. This is not just a hypothetical plan with exotic financing. This is this is what countries, high-income countries are already doing, and I actually hadn't known that Brazil had already done it. But if Brazil's doing it, I think that's totally understand why they're making that decision. And I think for those countries that are having problems with financing this, I would, as I was saying at the end, I think that it does make sense to go to multilateral development banks and to seek financing to help make these purchases. And so.
And Professor, do you believe that as Diffie and others have suggested, that start at least with a commitment to the equivalent of, let's say, 20% of one country's population, which in the case of Latin America would be, roughly speaking, 130 million vaccines, and that would basically take care, as you correctly pointed out, I mean, the obvious is the health workers, but then the people at risk, and then gradually move on. That would be, in general, the kind of model that you would follow?
Yes, I mean, look, I think there's a case for even, I think our model would suggest there would be the national self-interest of many countries to go larger than that. Now, there is a question, if everybody tries to do that, is that going to leave enough vaccine to go around? And maybe there's a case for some sort of system where countries would cooperate, order the vaccine, have that go to the places that most need it, and obviously start with the people who have the most health needs. I don't know, Susan, Camilla, do you want to jump in on that question? Or
I just
any other?
mention one thing, which is about that number of 20%. I think that is a great thing, but 20% delivered over 2 years and 20% delivered in 6 months are completely different things. And whenever these countries are trying to sign these deals, they should be worried also about how quickly that 20% or whichever number they want to buy, how quickly it's going to be delivered.
So, Professor, talk to us, because there's a number of areas here, and this has to do, of course, with the push as it relates to production capacity. I mean, just things like vials. I mean,
Right.
to produce 100 million vaccines is one thing, to produce 7 billion is another. And I think
Right.
from just behavioral economics, which you know well, I imagine the minute that you say everybody's going to want a vaccine, and you say, wait a minute, this is the order in which you get it, it creates all kinds of tensions throughout the society. People will find a way to go around the line because they want to be able to say, now I'm normal, I have a vaccine. Walk us through the supply challenges in the production and the things that you think countries can do, because clearly, in terms of just PPE, what we've seen everywhere in Latin America is, I never imagined to see, I know of at least 7 different projects of production of ventilators, some on 3D printing, others on hybrids, etc. But the reality is that here we are, every country had to produce their own PPE because you had all these huge shortages. And now we learn again here in the United States even that some hospitals, not all, but are having challenges with PPE.
So before Michael answers, maybe let me just underscore something that maybe goes by a little fast because we're so focused on it. And that is that the thing that we're suggesting countries sign up for is accelerated capacity expansion. And so, but one could imagine that mistakes could be made where you say, I'm signing up for these vaccines, but you don't have sufficient power in your contract that actually the companies are in fact creating the capacity to meet your needs. And so, the headlines are, I've got 200 million doses, but what you've got to care about is, is it actually credible that the company itself is going to be delivering those 200 million doses quickly? So I think that, behind the scenes, you need to be thinking about milestone payments, and you need to be thinking about ensuring that there's actually a plan and that the capacity is being expanded, which might mean signing up more contract facilities and so on. And if other people are signing up later, that they're also continuing to expand their capacity. And then the details of all of that are making sure that the vials are there and, all of the other components are available. So it's not just saying I've got 3 bioreactors, but they have to have a plan for all of it. And so, for the leading companies and the ones that with the most experience, I think it's not going to be so hard to write those contracts and for them to actually deliver on them. But you can worry that once you start managing, the newer companies or companies with less experience, they might have good intentions, but not actually deliver on time. And you'd have very little recourse if you get there and they're like, oops, sorry, like, oh, my fighter jet isn't ready on time. Like your house isn't ready on time. My vaccines aren't ready on time. If they're not ready, they're not ready. There's not a lot you can do. So you really are going to have to make sure that the steps are followed to get there so that you're not sort of surprised at the end. So, but Michael, why don't you maybe take the question maybe a little more directly?
No, I think that's great. I completely agree with everything Susan just said. The other, these, what are some of the important components? One, as you mentioned, the delivery mechanisms, the vials. Talking to people at CEPI, I think there was a lot of concern about that. The people at CEPI feel like they've made a lot of progress on that, and I think they have. Another is bioreactors. There are also things called adjuvants, which boost the efficacy of certain types of vaccines. I think one thing some of these inputs could work for many different, most clearly, if you think about the vials, that could work for many different vaccines. And when I argued one of the strongest cases for international cooperation was for the supply chain components, we don't know which vaccine will succeed. And I think there's something, if we think that there's implicit political pressures that make it very hard to be seen as profiteering, particularly for a multi-product firm that may be producing bioreactors, but that's a very small share of their total business. If you think about a firm like that, are they going to want to build an entire factory to increase production of bioreactors when it may be just a very short run increase in demand, and then their factory goes idle again? They may not want to do it because the only way they may be able to justify that financially is by raising their prices a lot, but that may expose them to political backlash. So I think just as we argued for vaccines, it makes sense for the countries or global institutions to sign contracts for to pay for the capacity itself. I think for some of these supply chain components, it makes sense to go to the glass vial manufacturers and just pay them to increase capacity, to build extra factories, and similarly for bioreactors, et cetera. And actually, we've seen that. The U.S. government is going out to Corning, the glassware manufacturer, and paying for increase in production of the specialized glass used for vials. I think there are benefits from international coordination on that, and we could get more of that. These are, thinking through those challenges is important, and to the extent we can expand capacity, we're going to reduce those problems. But it's definitely in the interest of each country to start signing up for supply now, I think, at least for the most vulnerable elements of their populations.
And then I guess when you sign the contracts also, they do need to have supply chain plans.
Right.
And you need to be tracking those plans. And this whole thing that Michael mentioned in his talk, like how terrible autarky is. So when we're just using that to flesh out what that means, we're going to have components of the supply chain in all different countries, and we're just going to have a repeat of the PPE problems if we're not careful about it. So, and then that can blunt the incentives to invest. Like if you're a country and you're thinking, I'm going to invest, but actually the vaccine candidate's supply chain plan depends on inputs from other countries, which I'm not sure I can rely on, then maybe you hesitate to enter into your original agreement. So one place where multilateral discussions among, finance ministers or others from each country to sort of get some commitments in place that, hey, we're none of us are going to invest sufficiently in this pandemic if we can't trust the contracts that we write. And it may be that in certain settings that entails actually thinking about, well, if I'm going to go to another country to get my glass, maybe I need to make sure that country that's manufacturing the glass has also got enough glass for themselves. because they're going to be less tempted to cause problems for you if they haven't been short-sighted themselves. And that, again, is a benefit of multilateral discussions, that, you know, it's really especially important in the countries that are doing production, that those countries have sufficiently have their own house in order well enough that they're not going to be tempted to sort of disrupt other countries' plans.
I know our time has run out. I know there's a lot of questions out there, but I really want to thank Professor Michael Kramer, Susan, and Juan Camilo. The reality is that after listening to you, this is a model, regardless, where you have to take out a lot of risk from private companies. It will lead to discussions in many countries if you should begin as a national security issue to have your own type of larger manufacturing going forward. If we believe that more diseases like this are going to happen in the future as you build up health systems throughout the world. But really, thank you very much. You give us a lot of food for thought. This is an extremely complex issue, but clearly our role, as you suggested, is fundamental, and we hope to continue to work with you and get all your advice as we go forward and look at the models that you develop. So again, Professor, thank you very much. Susan and Juan Camilo, thank you very much for your time.
Wonderful. Thank you. Very much enjoyed it.